starting, again, as I said a little while ago, we're going to be starting with our fluoroscopy discussions this week, starting with the esophagram and the upper GI. The alimentary canal begins with the oral cavity that we call our mouth, and it continues as the pharynx, which is broken into three parts: the laryngopharynx, the oropharynx, and the nasopharynx. That is followed by the esophagus, then the stomach, then the small intestine, and ends with the large intestine, where the alimentary canal ends with the anus. The accessory organs of the digestive system include the salivary glands, the pancreas, the liver, and the gallbladder. The exam that we use to interrogate the esophagus is called the esophagram, aka the barium swallow. Okay? It's a specific examination of the pharynx and the esophagus. For your notes, because it may come up again, especially on your exam on Friday, deglutition is the medical word that means swallowing. Also for your notes, the esophagus starts at the level of the lower border of the cricoid cartilage, right about here, of the larynx, and it terminates at T11. The upper GI series, we will also do positioning for that after we discuss the esophagus, is designed to study the distal esophagus, the stomach, and the first portion of the small intestine that is called the duodenum. The stomach is composed of three main subsections: the fundus, which is that upper part of the balloon. I love a picture and terrible drawings. Esophagus comes down, you've got the stomach here. Wow, realistic. Would you even know that's not from life? That's crazy. Okay. You guys were here for it. The fundus is the uppermost part of the stomach, balloon-shaped portion here. It's where you see that gastric bubble sitting right under the left diaphragm on an upright abdomen or a chest x-ray, okay? Then we have the body, right here, curves around. We've got the greater curvature of the stomach and the lesser curvature of the stomach, okay? The body continues into what is called the pylorus, or the pyloric antrum, okay? The pylorus is connected to the duodenum, which is the first part of the small intestine, by way of the duodenal bulb, okay? And that was the most important stuff you would ever know as an x-ray tech. You guys missed every bit of it. I'm sorry. Come on in. Questions on any of that so far? Okay. What we're also going to need to know about fluoroscopic imaging of the intestinal tract, or the GI tract, I should say, excuse me, is what position of the patient places the barium in what part of the stomach, okay? So if the patient is lying on their back, the contrast media is going to collect in the fundus. Who has a bottle of water? Anybody?
I do.
May I borrow it? Thank you. Can I have you take a big sip of it? Thank you. I know it's early. It's good for your metabolism. Not that much. I'm kidding. You're good. All right, I'm going to read my leg block too. Okay, so the easiest way for you to learn where contrast is in the stomach is to use a bottle and put it right here on your body, okay? So when I'm lying flat on my back, the contrast media flows into the fundus of the stomach, okay? When I'm lying on my stomach, the contrast media flows into the pylorus, okay? If I am upright, the contrast is in the pylorus, okay? You got to think about where parts of the stomach are and where the dependent portions are in relation to how the patient is positioned, okay? The smallest and widest part of the small intestine is the duodenum, or duodenum. For upper GI exams, and I would say upper GI exams, not really barium swallows, the patient needs to be what's called NPO. Very differing opinions on what NPO stands for. Some people say it stands for nil per Oz, which means nothing by mouth. NPO from midnight until the start of the examination for adults. Thank you so much, Andrea. Everybody will be trying to steal that from you today so they can get a For most adults, it's going to be NPO for 8 hours before the exam. Okay, so usually they'll have dinner and then nothing else after it until the next morning. We try to schedule fluoro exams early in the day, especially if patients have been NPO. Why? They're hungry. You want to really talk about a bad exam? A really hungry patient delayed for their upper GI exam. So food and fluids withheld for at least 8 hours. Why is it also important for us to withhold food and fluids for the exam?
To make sure the stomach's clear for the area.
Why is that important?
So you can see everything and not food in the X-ray.
Yes, what would food look like? It's called a filling defect. So food, if there's food still in the stomach, is going to present a filling defect that could mimic some kind of a pathology, okay? And the patient is also instructed not to smoke cigarettes or chew gum prior to the exam. Why would that be the case? Chewing the gum, well, that's a good thing. Yeah, we don't want them to swallow the gum, but chewing the gum is going to stimulate the gastric mucosa to create fluid, right? Which is going to dilute our barium. And we don't want them to smoke because that is going to increase the motility of the GI tract as well. Okay? Questions? For little bibbies, we have different NPO periods. Obviously, we don't want to keep a little newborn NPO for 8 hours. So for infants younger than 1 year old, they're only NPO for 4 hours. Children older than 1, NPO for 6 hours. The barium is what we use most of the time for an upper GI exam. What would be a reason why we wouldn't use barium for an upper GI, or barium swallow, or a stomach exam? Sorry? Sure, but most people wouldn't be allergic to barium. Generally speaking, most people aren't, thankfully. Sorry? Perforation. If they've recently had surgery, if there's a concern, if they came in through the ER, there's a concern, there's perforation, we don't use barium because it never gets absorbed, okay? Remember, barium is a suspension, it is not a mixture, okay? Barium preparation, newborns to 1 year old, they're gonna get 2 to 4 ounces of barium. 1 to 3, 4 to 6, 3 to 10, 6 to 12, and older than 10, 12 to 16. This is a very nice little line of information that will go right out of your head once you leave this room, because the barium amount is going to take what it takes, right? But for our purposes, for your test especially, I'll try to make sure you know those different amounts here, okay? For fluoroscopic exams, it doesn't matter what it is, I want you to take this rule forward for every exam ever. Actually, even radiographic exams, we've already said this before. Keep an eye on your patient. Most important for a fluoroscopic exam, the radiologist is going to come in and they're going to be the one who pulls the fluoro tower over, and they're going to be doing the exam, looking at the screen. They're never going to look at the patient. So whose job is it to look at the patient? Hello. Yes, all of you. So keep an eye on the patient. Watch the table movements. I've said this before too. Again, the radiologist is going to be moving the patient either with buttons here, or he's got a little switch or joystick, whatever. He's not going to be looking at the patient. If the patient for some reason decides that they need to put their hand here and the radiologist moves the table that way, what's going to happen to their fingers? Ouch. Okay? So watch table movements. And for fluoroscopic exams, as with any exam, but especially for fluoro, you want to make sure that you ensure the patient's comfort. Okay? They're going to be doing a lot of moving on this table. They are already in some kind of distress, probably, right? They're in the hospital for a reason. If they have really bad abdominal pain or they're post-surgery, we want to be sure that we're just helping them to be comfortable during this exam, okay? So that we can get the exam completed as efficiently as possible and get them back to their comfortable bed. Okay? Questions on any of that? Anything to add? All right. And to start off with, come on over and feel some barium. So, if I have a patient who had some kind of an esophageal surgery or stomach surgery, I'm going to use water-soluble iodinated contrast media, okay? Because it's going to be reabsorbed into their body and filtered out by the they lose really easily, okay? This is one called VisiPake. Use it a lot in the pediatric environment. Thin barium, thick barium. Thin barium flows like milk. Thick barium coats the inside of the esophagus and the stomach, okay? So take a moment, come over and feel the difference in weight between these two, okay? You guys are lucky. Whenever I was in my program, my instructor made us taste the barium. It's actually pretty good. And I'm also not telling you that we used to chug a little bit of it whenever we would have a night drinking before. Yeah. It's good for stomach upset.
Is there a reason for dinner?
Thin barium flows through. So thin barium is used mostly to show the shape of things, okay? Whether there is some kind of an abnormal narrowing of something in the esophagus or the stomach, for example. It's good for showing transit time, right? You can see how quickly it moves through their GI system. Thin barium is like taking a milkshake and throwing it at the wall. It's going to coat the wall, right, and move very slowly. Okay, so we use thick barium with gas crystals to help show the inside to see if there are any polyps or any other abnormalities actually with the lining. Okay, so thin barium for the shape, thick barium for the lining. Okay, it's going to coat. Again, barium sulfate never dissolves in water. We have to mix it thoroughly. So you're going to fill this up, either one of these or both of these, to the top with water. If it's thick barium, you're going to do this the entire time you're waiting for the patient to come to the room, okay? And then before you start, you just want to make sure you give them one more shake before you give it to the patient, okay? Because it will settle, because it is a colloidal suspension. Thin barium, 1 part of barium sulfate to 1 part water. Thick barium, 3 or 4 parts of barium sulfate to 1 part water. It's the difference in the weight per volume, okay? The contraindications, again, to barium sulfate are any recent GI surgery or any chance that that mixture of barium might escape into the peritoneal cavity. As we've said before when we talked about contrast way a long time ago, it can lead to intestinal infarcts or barium peritonitis, okay? If we suspect that there is some kind of a perforation, we're going to use this water-soluble contrast. Again, for the reasons that I said a moment ago, it's going to be absorbed very easily. So that'll be something like Omnipake, GastroView, VisiPake. Omnipake, I think, has an osmolality of 240, so it's called Omnipake 240 or 270. VisiPake 320. That refers to how much iodine is in this mixture, okay? And if this escaped into the peritoneal cavity, then the body would reabsorb it. Double contrast exams take advantage of that thick barium and the ability of the thick barium to coat the inside of things, okay? So we use radiopaque contrast medium, usually thick barium, and some kind of a radiolucent contrast medium, usually gas. So what we'll do is we will give the patient gas crystals followed by a little water. We're going to tell the patient not to burp, even though they're going to feel the need to do so. And then we're going to give them the thick barium. Those two together are going to create that double contrast to help us see the inner mucosa of the esophagus or the stomach or whatever, okay? Radiation protection. You already know that fluoroscopy is one of the areas of our job where our occupational exposure is the highest, okay? With that said, don't stand right next to the patient the entire time, okay? While you're watching the patient, you can still find opportunities to stand back a little bit, okay? You can still keep an eye on the patient, or you can stand behind the radiologist. They love that, especially when you tickle them while they're doing the exam. I'm totally kidding. Please don't do that. Okay? So don't stand too close to the patient on either side. Stand on either side of the radiologist or behind the radiologist. Stay back from the ends of the table. Okay? As you saw in your book, there are radiation ISO lines in this area. The fluoro tower has a lead drape here. When we move the bucky to the end of the table, it engages a lead flap here that protects us too, okay? If we're at either end of the table, there is no protection. You're getting that full, unfiltered scatter radiation right to your bodice, okay? So again, lead drape shield, bucky slot shield, those will protect you here if you're the operator, and we wear a minimum of 0.5 millimeters of lead shielding. The upper GI exam, part of the upper GI exam at the end is to evaluate for gastroesophageal reflux. It's one of the main reasons why we do an upper GI exam, okay? And the radiologist is going to test for that in a few different ways. They may do the Valsalva maneuver, where the patient is asked to take a deep breath, and while holding their breath, they're going to bear down as though they're trying to move the bowels, okay? So they're trying to go, forces air against a closed glottis. The other thing that they could do is called the water test, or the water position as it's written here. We're going to give the patient barium, and then we're going to have them drink water. Why would we not have them drink more barium if we're looking for reflux? Why would we have them drink water? Oh, critical thinking's hard at 8:15 in the morning. No. Good guess. Because if I have them drink more barium, I can't tell which barium is sloshing up into the esophagus as reflux. If I have them drink water, I'm going to see that water cause that reflux, and that barium is going to pop back into the esophagus. Okay? It'll make it easier to see that reflux. Compression paddle. There's also a paddle that has a little inflatable balloon on it that the radiologist can use to actually physically press on the outside of the patient's stomach to see if they can elicit some reflux there. Okay? Finally, the last thing is they would have the patient touch their toes to see if that is going to cause some reflux. Okay? Basically, all of these are testing the patency or the competency of that lower esophageal sphincter. Okay?
I have a question. Going way back to the intake of that,
Yes.
how do they intake it? With the little baby, like how do you get it all down?
In a baby, you give them a bottle,
Okay.
and we're usually you're not going to do thick barium or double contrast on a baby. Usually it's single contrast, because the things that happen with babies tend to be things where they're developmental issues. Like they'll have an abnormal thickening of a muscle that causes their stomach not to empty, or they'll have some kind of a narrowing of their esophagus. So we're looking at the shape, so we're only going to give thin barium. Okay?
And then for adults?
For adults, it depends on the history, but yes, we would either use both of these, and it would be through, thin barium is going to come through a straw. Thick barium is actually, it's a little difficult to pull through a straw. You can, but it's like pulling through a thick milkshake, you know. Any other questions? No. Okay. So after the radiologist has come in and done all of their fluoroscopic exam with the fluoroscope, okay, they're going to be watching things happen in real time, watching the patient drink this contrast, following it through. Then they're going to say, can you get me some overhead images? And these would be the overhead images. If we're just doing an esophagus or an esophagram, I'm going to use a 14 by 17 lengthwise cassette. Makes sense. The esophagus is about right here. Okay. The first position we'll do is an RAO, 35 to 40 degree oblique, not full 45. Okay. Their left arm is going to be up. Okay. And their right arm is going to be down, or it could be holding a cup. Depending on the position, it's kind of hard to hold a cup if you're in RAO position. So you'll probably have to help them drink out of that cup, okay? We're going to take that off. I hate that. CR is centered to the level of T5 or T6. It is at the sternal angle, or where the manubrium of the sternum meets the body of the sternum. So about right here, okay? Or 2 to 3 inches below the jugular notch, okay? Then we do a right lateral. Why would we do a right lateral instead of a left lateral? Sorry?
Where the stomach is at.
It is, yes. But specifically, when the patient's in a right lateral position, their duodenum is the most dependent portion now. So they're lying on their right side, the stomach empties into the pylorus and into the duodenum, so the radiologist can evaluate gastric emptying, okay? Okay. And then finally, an AP or a PA. Okay, AP would be preferred, just again for ease of the patient drinking the contrast media and having the contrast flow through the stomach. Okay, well, actually, for the AP, it's going to kind of sit in the fundus, but that's fine. Okay, so that's what we're going to work on first, the esophagus. Okay, questions? Anything to add?
Can you repeat what you said about why we do right lateral?
Right lateral is done because the shape of the stomach, the orientation of the stomach, when we do right lateral, it helps that contrast media flow into the pylorus and then empty into the first portion of the duodenum. Okay, so the radiologist can see that C loop of the duodenum in profile. Wow, it's hot. Questions? So in an adult environment, we're going to do an esophagram for evaluation for cancer, evaluation for esophageal changes, for reflux, to evaluate partially for reflux, but the upper GI is really going to be for that. Oftentimes in an adult environment, you'll be doing an esophagram because there may be a concern for some kind of esophageal cancer. Questions?
Patient communication is the most important with fluoroscopy examination because when we get a regular x-ray, like a wrist x-ray, it is important to know what happened and what's going on. But when we're doing an upper GI, we need to know more information. We need to know, honestly, the most important is we need to know if they got a CT earlier with contrast, then we can't do it because there's already contrast in their stomach. So we need to ask a lot of questions when it comes to fluoroscopy.
Questions? Okay, so now we're going to work on those 3 positions there, okay? I feel like you guys could pretty much get through this pretty easily on your own, but we will show you. Okay, who wants to be the patient? Great, we're doing great.
I'll do it because I don't feel good anyway, so laying down sounds perfect. I'm gonna put my head right here.
Yes.
Lay on my back.
No, lay on your stomach. Okay, so left arm is going to be down, or up, excuse me. Right arm is going to be down. There you go. You're going to have the patient rotate slightly away from you, okay? So bend this knee up just a little. Bring it up. Sorry, like this.
I can't see.
There you go. So bring it up alongside you. Bend it up. There you go. Rotate your body. Bring that leg down. and now rotate your body. Put that
You
hand.
could say left or right. You're very bad at communication. I don't know. Do this. Okay, where?
You got there, didn't you?
Yes, hallelujah. Oh, so good.
Optimally, you'd have a patient better than April, one who doesn't talk as much.
I have reflexes, just FYI. Ooh,
You have reflux or reflexes?
reflexes. Oh, I don't know, not today. Well, I don't know if you're fixing it or.
No, you're great. You just stay right where you are. Let me work around you, okay? So when you're doing the RAO, you're going to be centering a little higher than you would for a chest x-ray, which means you're going to have about 2 inches above the top of the shoulder, okay? Whereas maybe for a chest, you would only have like an inch and a half, okay? Centering a little higher. Because the esophagus is going to be thrown slightly onto the left side, as you see it here, your centering is not going to be exactly on the MSP, so it can be a little to the left side as you see the patient, okay? Then they're going to bring this arm down, and you're going to either give them the cup to hold.
I don't have to drink this.
No. Yes. Or
I choose.
you can stand here. Actually, you can't stand here and hold it because you got to make the exposure. So you're going to give this to the patient. It's going to have a straw in it. Before you make your exposure, you're going to say, okay, start sipping, okay? Because you want to make the exposure while they're drinking the barium, okay? So that their esophagus is full of barium, okay? Question?
Oh no, it was just the inside thing. Let me drink my stuff.
Okay?
Have you ever laughed with one of these? That was all. I was not paying attention.
Questions?
Okay, what if this is kind of an awkward position for the person? You put a sponge here?
You can, but they're not going to be there long anyways.
Oh, okay.
Okay. Now we're going to do right lateral. So April, lay all the way on your right side.
Where do you want my right arm?
You can bring them both in front of you, okay?
I don't fall.
Okay. Arms over the head, or they could be in a swimmer's position too, if that would help with the drinking.
Well,
But usually, you can have both arms up, yeah.
yeah, this is kind of odd to drink.
Or alternatively, if it's easier, they can bring this arm behind and then rotate back slightly.
Oh, that's
there we
better.
go. And then they can hold the barium in this hand and then take a sip like that, okay? This is called like a swimmer's-ish position, okay? Very technical terms, TJ. Okay?
This is better than but why I just like. Well, I'm just being honest. Like, there's no way I can drink like this. Like, it's
Well,
not.
we give you a straw.
Yeah,
Oh.
It's
yeah.
reaching your mouth. I need
Oh.
to do this.
Oh, okay. Then that's fine.
You should definitely keep complaining though, April.
You said to do that in as a patient so that it can help our patient care. I can't think today. I'm still in the same position I was in.
Okay, right lateral, okay? Centered at about the level of T5 to T6. And then finally, lay on your back for me, okay?
And why do we have to do, oh, that's in the position ordered that way, just out of curiosity?
So we start with the RAO because, why do we start with the RAO? I would say we don't start with the RAO.
Just say that's the way it is, and then I say, okay.
Honestly, it's kind of like when the doctor tells you to take overheads, he tells you exactly what overheads you want. So he'll tell you, "Oh, just get a lateral," or he'll be like, "I want RAO and lateral," or like what So it doesn't really matter.
Okay, just do it this way.
He'll tell you what overheads you want.
Okay.
And for the esophagus, it really doesn't matter as much as it does for the stomach what order you do them in, because the stomach, you really do have to be careful that you don't like obscure things by giving them too much barium and turning them in the wrong position first. But for the esophagus, you're not waiting for anything to fill or empty. So
because it's at the same
it's just,
time.
yeah, we're just looking from here to here. Want that tube to be full of contrast. Okay, great. And then I would have her turn her head this way slightly. She would kind of hold this awkwardly with that hand and then take some sips while I'm making my exposure. Okay? Easy peasy? Could be worse, right? There could be all kinds of angulations. Okay. Questions? I think April wants to stay here. Anything else to add? It's been a long time since I've done an adult upper GI. Most of mine were pediatric, so if there's anything that I missed, please let me know. All right, guys, have at it with those three, and then we'll move on to the upper GI, okay?
Very good.
And this one is open all the way, just lengthwise?
Yeah.
Lengthwise, full 17, and then collimate down to like a 7-inch wide field. Maya. Great. Vivian. TJ. Carissa. Christopher. Ledesma. Estrellita. April's here. Isaiah. Kayla. Dimitar. Joy. Kumi. Josh Paulo's here. Marianne. Andrea. Victoria. Hello. Katerina. Chris Poo. Ji-Yun. Enio. Didn't even put my marker anywhere. That's what I forgot. Just out of the field to the edge. Okay.
Just like it's fine how we put it on the corner.
So for the esophagus, I would say it matters less. You just want to make sure that it's marked correctly. Okay, so if you're putting your marker like for the RAO, you can put right or left marker, just make sure it's marked correctly. Okay. Barlow called me at 3:18 a.m. We have a stat X-ray in ICU. I wasn't on call. So my phone rang and woke me up, and I was like, back to sleep. I was like,